emergency physician from New Jersey at Claremont, our EMA brother in arms here, coming to give us a lecture on how to code for observation. For a long time we've heard us talk about perhaps building out an obs unit, et cetera, et cetera. Well, it turns out, we can actually code for observation medicine that we are doing presently. And Dr. Ellis is going to go through that length. And there are a number of various clinical encounters where we're basically giving that level of care. The reason why we want to do that is it's a service we're already providing and helps us capture our views that we are currently generating. So I want to say thank you for coming out from New Jersey and enjoying our wonderful weather.
Thank you for having me.
Thanks for coming. I just want to also just introduce Dr. Nelson Fox, our colleague on the West Side JCL is here as well. Thanks for coming. We will make all of this presentation available on a link to a Dropbox. So those that aren't here, I'm sorry to tell you all before you show up. So those that aren't here will have all this because this will be in PowerPoint as well. So turn to you and thanks.
Okay, thank you. Morning, everyone. I'm Rob Giles. I worked for EMA since 1998. Now that we've merged with MCare, I do some documentation and coding advisory work for RTI. I'm actually an emergency physician, but also a certified coder as well. And so we've been doing observation for probably a decade now. So although some of you may have stayed home, had you known this would be available on the web, a lot of times it works better in person because you can get your questions out. You can get over the hurdle of, is this an appropriate service that we're providing? And as you'll see as we go through the slides, these are actually patients we're already taking care of, already providing the service. We just need to restructure how we document that in some ways. Okay, next slide. So these patients that we're talking about, they're already spending lengthy times in our emergency departments. Their intra-service time far exceeds 2 hours, which is our threshold for when we code or we document for observation. So you'll find that many times you're providing all the services, you're providing the documentation, but you may be missing a few key words, which will actually allow you to code for observation, in addition to the RVUs that come along with that. And the reason that you get additional RVUs is from the insurer's perspective, you're allowing them to not require an admission for that patient, which is a much larger cost for them as well. Next slide. Okay, so for a physician or a provider to bill observation services, there must be an order for observation within the record. And sometimes this becomes confusing because if you look through the CPT guidelines, really there's only an order required for Medicare. But just to be uniform and standard, you'll find that many of our health systems will require an order for all payers. So we put an order for observation in the enterprise system. In addition, there's going to be a necessary statement, but that's usually composed in your macro in that first statement, which tells the reason why the patient requires observation. Something along the lines of patient presented for abdominal pain requires observation for further evaluation and treatment. That will usually be the beginning statement. Okay, next slide. So we talked about, the CPT requirements for that order or that statement, but also it requires that you have ongoing reassessments. It does not delineate how many reassessments that should be. However, arbitrarily, we've stated that would be 3 reassessments. And because we have some typical times for different levels of observation with these reassessments, it lets us know that we provide enough documentation that it will assure that we meet those time standards and we won't be questioned on those when it comes to an audit. So there's going to be an initial statement, there's going to be 3 reassessments, and there's going to be a discharge plan. And many of these things are very simple and straightforward, and as we talk about them more, you'll see exactly. Here we go. Okay, so observation care usually completed in less than 24 hours. As you'll note, many patients we admit to observation in the hospital. If we're going to admit the patient to observation, you can't put those patients in observation in the ED, or usually you wouldn't want to because there's only one professional fee for observation per day. So if I code for observation, the internist or whoever takes care of the patient is not going to get paid for that service, and usually going to come downstairs kicking and screaming. So we look for patients where we can arrive at a disposition in the emergency department. Now that may be abdominal pain, but usually we're going to make some conclusion before we change the status of that patient. We're going to evaluate them, reassess them, maybe get a CAT scan. We decide it's not appendicitis, they don't need surgery, we discharge them home. Or we find that it is some medical catastrophe within the abdomen, we're going to admit them, we're going to send them to surgery. That's a different disposition than observation. The two will not conflict. And so we tell our providers, usually to avoid conflicting with the in-house staff. So if I see an abdominal pain patient, I find a finding on the CAT scan that I need to admit them for, they need to admit the patient, not put them in observation. And usually in those instances, we won't retract our observation because we're using the code appropriately. It's the next provider who's not. Okay. So the different levels of service. 99234 actually would correspond to a level 3 patient greater than 2 hours of service in the emergency department. 235 would correspond to a level 4 patient greater than 2 hours in the emergency department. 236 corresponds to a level 5 patient greater than 2 hours of service in the emergency department. So moderate and severe, moderate and severe correspond with level 4s and 5s. Usually if it's of a low complexity enough that it's a level 3, we don't keep those patients around for prolonged periods of time. We send them home, have them follow up with their providers. And as you can see, the typical times are 50 and 55 minutes. By our arbitrary threshold of 2 hours, with our reassessments, our discharge plan, we won't be challenged by anyone on whether or not we met those standards. And that's the reason for the arbitrary time. Next. So that's observation services on one day. So we should make a distinction. One day, all the services doesn't cross over midnight. That's 235 or 236. Observation services where it does cross over midnight, where we have 2 calendar days, we've set a threshold for 2 hours, but also you have to have at least 15 minutes on day 2, and we'll discuss why that is. So 218, low severity, that'd be a level 3. We're not observing those patients. 219, level 4, greater than 2 hours, at least 15 minutes on the subsequent calendar day or on the first day. So if you started with that patient at 11:45, kept them around to 1:45 a.m., that would be an observation opportunity, and you would use the 2-day codes. 220, level 5 patient, same parameters, 15 minutes on one calendar day, hour 45 minutes on the next. And this is our discharge code for that day 2 service. So you can see, based on what's required within that code of doing the reassessment, assessing their discharge plan, we feel that 15 minutes is a reasonable time. If you put it down to 1 minute, could you really accomplish all that in 1 minute? So we feel that 15 minutes is a reasonable amount of time. So start at 10:45, complete at 1:45 a.m., 219, 217 for level 4 patient. Start with 10:45, conclude 1:45 a.m., 220 and the 217. The only caveat to this is, if you can go ahead. We'll get to the Medicare distinctions as we go along. So most of the clinicians, the payers, they agree that this is to avoid a costly admission. We get additional revenues for observing these patients, and usually what it comes down to is diagnostic uncertainty or disposition uncertainty. I'm not sure what I'm dealing with. I need more time, more studies to further figure out exactly what I'm treating. So if it's abdominal pain that is not severe, they can go home, or if it's abdominal pain that needs surgery. Same thing with disposition uncertainty. Maybe I can hydrate this patient further and get them discharged instead of admitting them. So we use it for gastro, we use it for dehydration. Abdominal pain is a typical patient, even intoxicated patients. And many folks had a problem with accepting that because we have our routine drunks who come in. You sit them in the corner at 6 a.m., you discharge them. But actually, that's a patient you're taking care of. Someone should be reassessing them throughout the night. So if they're here for 8 hours sobering up, someone should be making sure that their mental status is improving. You should be making sure they're ambulatory, they're tolerating PO before they're discharged. Because if not, we're gonna have a change in how that patient is being treated. Chest pain is one we're also cautious about. Many times our chest pain patients or our low-risk chest pain patients get admitted to observation in the hospital. So we have to be sure that this is a patient we're going to disposition. We're going to do a repeat troponin and repeat EKG. We're going to send them out to follow up their cardiologist, or we're going to find that their enzymes are positive, in which case we're going to admit them. So you got to have in mind exactly what's going to be your disposition point on that particular patient. And you can see our other examples, renal colic, syncope, even our psych patients. When it comes to overdoses, you want to keep in mind some are simple overdoses. They don't have any systemic effects. We evaluate the patient, we send them home. Some patients we need to do reassessment, so Tylenol overdose. Maybe we need a 4-hour level. That's a good observation opportunity. TCA overdose or something with hemodynamic compromise, that's probably more of your critical care patients that you're doing. So just keeping in mind when that opportunity does arise. Next slide. So observation is initiated. Medicare requires an explicit timed order. We're going to put that order in for all patients. So that triggers within our billers to look for that. And what we're going to do here as we embark on this, we're going to keep a list of each patient. We're going to send them over to RTI, make sure they don't miss out on collecting for that when we're doing our documentation. CPT only requires a written statement, but we're going to do both for all patients. Order an enterprise system, first statement, patient requires observation for whatever reason, time stamp it, and that starts our observation service. It is appropriate if you say you have a abdominal pain patient, you go examine them, they're non-tender, you think you're going to disposition them, and as you're doing their workup and their paperwork, they start vomiting. You have to reassess them and change your course. It is appropriate to start your observation time from the first time you saw that patient. That's understood within the documentation realm, and that's totally appropriate if you back time that order. That's no problem. Because all of this is considered you were already taking care of the patient. Next slide.
So Rob, I'm sorry,
yes.
you also said that you mentioned just kind of briefly you can retract it, so if something, if you kind of have your best estimate, and then it turns out that you can't send them home, they didn't meet an inpatient status. You said you can retract the observation if you have to?
You can, because essentially RTI is not going to be an observation until you send the chart over to them. If it's a patient, maybe it's just a day when the ED is not busy, it's a renal colic patient, you put in your labs, your CT, everything comes back relatively quickly, you haven't met the 2-hour threshold. If you just simply put in there 1.5 hours, they're not going to code for observation because you haven't met the 2-hour threshold. In the other instance, say it's a chest pain patient, you plan on doing that 4-hour repeat troponin, the cardiologist comes down sooner, takes the patient, wants to make him inpatient, you can just cut it off. If you put in less than 2 hours, they won't code it. The other way is if you just remove observation from the initial statement and the time statement, you won't meet the requirements either. And so those are ways to kind of avoid conflict. So Medicare policy says for observation for 1 day, that's the 235 and the 236 codes, you need 8 hours on 1 calendar day. However, when we're doing observation for the patient, these are the appropriate ways that we treat the patient. We still put them in observation, and what's going to happen is they're going to code for the fraction of observation. So they're going to use the 219 or the 220 without the discharge code. But essentially, you guys don't have to worry about that. That's the billing company. All you do is document the services that you're providing, you put in your times, and you let them worry about that. You let RTI figure out which is which. For non-Medicare, there's no 8-hour minimum. It's just our 2-hour threshold. Next slide. So what's included in observation? Bedside time, time spent interpreting diagnostics, time for reevaluation, conversations with family and consultants, and essentially once you meet all of those criteria within your care for the patient, and the patient must remain under the care of one of our providers for that total time. So if you transfer them to a provider of another service, that ends the time. If you admit them, that ends the time, or you discharge them. So those are the things when observations concludes. Okay, next. And as you can see, that last statement said that it's a status, not an area. So many people think of an observation unit. You really don't have to have an observation unit. At my site, we actually do both because we do have an RDU, rapid diagnostic unit, which is actually an observation unit. But there are some patients that we don't necessarily put in there, we keep on for ourselves. You know, usually the more rapid turnaround patients, so the abdominal pain patients, the renal colics, where it's only going to be 2 or 3 hours. We don't necessarily put those patients in the observation unit. For the patients, chest pain, they're going to get repeat enzymes, they're going to stress test the next morning. Those patients probably go to the observation unit. So time ends when there's a disposition decision. Patient's admitted, transferred to another provider, or they're discharged. It's not utilized for bed delays. So if we have an ED hold or there's a delay for some other reason, we don't document that in the chart. It's really when we feel like the intra-service time is going to be more than 2 hours. And we know for those abdominal pain patients, getting labs, getting meds, CT, that's going to be a prolonged course. We need to repeat the enzymes for the patient who presents relatively quickly after their chest pain episode, gastro, we want to hydrate them for a while. All of those patients are going to have a long intra-service time. Not for the patient where you want to admit them and they just say, oh, there's no bed available, and they're going to be here for a few hours. We don't use it for that. So documentation requirements. Order for observation, time notation, when the patient was placed in observation, periodic reassessments. What this says is every 1 to 2 hours. That's kind of our old model when we were using a prolonged time. Now it's just multiple reassessments. Because as you can see in the 2-hour time frame, you may reassess the patient 3 hours. Obviously, it's not every 1 to 2 hours. So just multiple reassessments. Documented discharge evaluation. Post-discharge care plan can be as simple as follow up with your PMD, follow up with the cardiologist. You need a stress test. Something very simple and straightforward. It doesn't have to be very elaborate. And you need to meet all of these requirements. What we have is a macro, and we tell the providers, don't delete anything out of that because each one of those is a necessary input, and I assume you guys are going to create the same mechanism. Okay. So observation discharge code. The 217, it says that you do the reassessment on the date of this observation discharge, and you also do the discharge care plan. And that's how we came up with the 15-minute threshold to make sure that you meet all the requirements that are included in there. So when we started this RTI, for some of the other sites other than our division, they probably have a 1-minute threshold. But we feel it's a little more accurate to have 15 minutes to do all of these particular services. Okay, next slide. So documentation of time required for observation, order, continued evaluation, treatment, episodes and discharge, the documentation requirements, order for observation, time notation of observation, time periodic reassessments, documented discharge evaluation, post-discharge care plan, and we're not going to use this for bed delays. Okay, and as we said, status, not a place, doesn't need to take place in an observation unit. These are many patients we already have in the ED. We have them for a prolonged period of time. We turn them over to our other providers. We should be making this easy for ourselves to document observation. And what you will find is when I go out and I review charts for some of the sites, you'll find multiple reassessments in the chart, and they're actually performing observation. They just haven't triggered it with the initial statement or with the concluding statement of what the disposition is and how long all of that service took. Next. All right, so this is kind of a breakdown of each one of those components, and this is what your template would have. So our template has, a beginning statement, it has an insert point for your reason and your time. Then it has 3 reassessments with each one of those where there's a clinical input to that statement. One of the hurdles we had to overcome is when you have those reassessments, you find that some of the providers will put in patient sleeping comfortably, patient in no distress. We need something a little more defined in there so that it meets the requirement of we reassess the patient. And it can be patient tolerating PO, abdomen non-tender, no respiratory distress. If it's a tachycardic patient, you're hydrating them, you can comment on the heart rate, but just things that are very nebulous, like sleeping comfortably, probably doesn't meet the requirement. Okay, next slide. So for educational purposes, the RVU value, we're allowed to give a range that's somewhere between 3.76 and 7.27 RVUs. And if you compare that to, say, a level 5 patient, maybe 4.9 versus 7.27, where you've provided all those services for that patient already, and those are all of the RVUs that you're leaving on the table when you're already providing the service. Okay, next slide. So this is what the framework of a macro would be: patient place and observation at such and such time. For uncertainty, you tell what you're evaluating with abdominal pain, dehydration, chest pain, one-time reassessment. We want 3. This one has 5. It's not necessary. 3 is kind of our threshold that we work with. Discharge examination reveals abdomen non-tender. Decision was made to discharge the patient. Follow up with their PMD. So you would build a macro which addressed all of those things.
Excuse me.
Yes.
So for those times, do you typically use your initial and your last? So really you're only doing one in between?
You want to go back? So your initial time is just why you put them in there, and then you would probably use your first examination, then you would have 2 follow-up examinations. Okay? Not just one, but because you want to have 3 reassessments, 3 times that you kind of touch base with the patient.
And there's going to be one at the end. So
There's definitely,
adding one.
we can already understand good medical practice. You're going to have at least 1 reevaluation before you discharge that patient. But we want to have 3 for the observation. It kind of differentiates a standard evaluation versus an observation evaluation. Okay, let's go forward. And this is that framework kind of filled in what it would look like. So patients being observed in the ED for abdominal pain, intractable vomiting. You can see they received some analgesics, antiemetics. They're improved. They were reassessed an hour later. PL fluids, they tolerated, and we were discharging that patient home. And as you can see, that's a 2-hour and 10-minute turnaround. But actually, that's what we're doing. We're observing the patient. We're making sure that they improve, that it's reasonable to discharge them home, and they're not at risk. A lot of times when we see patients like this, we kind of downplay exactly what we're providing for the patient. We're seeing them, oh yeah, I think I'm going to be able to discharge that patient, but there are actually some steps in between where I reassess them before I do discharge them, and that's the definition of observation.
So Rob, so that one has 2 reassessments documented, and on the last one, we assume is the reassessment before discharge.
Mhm.
That would count.
Yes.
And then, do you back time to the time that you first saw them for everyone?
Okay, so say you saw this patient and you thought they had gastro, and you're thinking, I'm going to discharge them, and I go in, I'm going to give them a dose of Zofran, I come back and I reassess them. They're not improved enough. They didn't leave in like 1 hour. So then I would go back and put in the initial time that I started with the patient, and then I'd put in my reassessments. But the thing about it is going, from the beginning, you can understand that this is going to take a little bit of time, and that time is still going to be the same.
And so realistically, you could, before you discharge them, realize that you kind of met all those criteria, even though you hadn't said it earlier, you could put a statement at that point,
Yes.
based on observation. You've got documentation to support it, and so you can do that at any time.
Yes, absolutely, because you're actually already doing that. And that's what you're going to find is, yesterday you were treating these patients, doing reassessments, and then tomorrow you're going to be treating these same patients. You're just going to put in some additional documentation. I realized I'm observing them for abdominal pain and vomiting, and I did that for 4 hours. So it's the same group of patients. It's just making your documentation more robust to reflect exactly what you're doing. Okay, and this is the 2 reassessments, and then the discharge assessment, and then the discharge plan of care. And from RTI, they kind of made this really detailed. Some of these things can be really straightforward. Patient given antiemetics, told to follow with the PMD in 2 days. It doesn't have to be really drawn out. Okay, next slide. So this is where we have some vignettes of typical patients. So 48-year-old epigastric pain. We put in some vitals. They've got pain in the right upper quadrant. We give some antacid treatment. We shoot a chest x-ray. We do labs. We get the EKG because epigastric pain. We place them in observation status at 0022. So we do the ECG. Patient discharged home at 5 a.m. with a diagnosis of gastritis. Minus this statement, this would be a typical patient. What we want to recognize is all these things that we're doing in between, we should be doing our reassessment to capture the RVUs for this treatment that we're providing for this patient. Okay, next. Because as you can see, that patient had 5 hours of service, but they didn't have the reassessments, and they didn't have the total time in observation placed on there so that you could collect those RVUs. So 49-year-old abdominal pain, suprapubic right lower quadrant. We do a set of vitals. CT is ordered to rule out appendicitis, give a bolus of fluids, Toradol, Zofran, place an ops at 2100. First reassessment, they still have some tenderness. 2 through 4, symptoms improved. We're thinking appendicitis, cholecystitis, pancreatitis. We get back our CT. We got abdominal pain, right lower quadrant, it's negative. We say it's just gastro or some abdominal spasm. Discharge them at 3:41. Total observation time, approximately about 7 hours. So this would be an observation case for us. And we would expect RTI to pick up on the patient that we placed in observation, we did our reassessments, and we discharged home, and then maybe some simple discharge plan such as follow up with your PMD. Next slide. So what we're trying to do is not only bolster our documentation, but also at the same time we benefit by capturing additional RVUs. So 60-year-old abdominal pain and vomiting, we get the history, we do some labs, EKG and CT, give some analgesics. You stop by to see if the patient is drinking contrast, find that they're still in pain, give additional medicines. 2 hours later, the CAT scan of diverticulitis is diagnosed. Labs are okay, slight elevation in WBC. 4 hours into the stay, the patient says they want to go home. We give them IV antibiotics. We say there's focal diverticulitis. We feel it's safe to send them home with some PO antibiotics. That's an observation case. Very easily, we could have admitted the patient for diverticulitis. Still, we have a disposition. This just happens to be one that we sent home. So as you can see, this would be a reassessment here, additional reassessment, and this would be the discharge reassessment here.
Let me ask you, in a
Yes.
patient like this very case right here, where you're documenting your reassessments, you end up discharging them with discharge instructions, everything. Can we simply put in our medical decision making, as we talk about the case, they came in for diverticulitis, there's no perforation, they're feeling improved, they declined hospital admission. Can we, in that medical decision making, say, oh, by the way, at 2000 hours when they presented, we place them in observation status? Can we add that at that point, and that will complete all our requirements for observation?
That would, but that may not be the best use of our documentation, because what we're looking for is we want to make it easy for the coder to pick it up, and that may be embedded, they may overlook it. So just put it in a framework that they're accustomed to seeing, they pick up immediately as they're looking through this is an observation patient. So then it triggers, okay, I'm looking for the reassessments, I'm looking for the discharge care plan. If you put it at the end, they may not have been thinking that and they miss it, or it's not quite as sufficient, now they got to go back. So we're just trying to put it in a very stepwise fashion and make it easy.
And a separate entry into like the ED course, for example, would that suffice?
Actually, you would put it beforehand. You kind of want to trigger it, that's what I'm thinking, beforehand. Because essentially for these patients without that, the billing company probably could see that it's observation, but that would be upcoding. If we got audited, that wouldn't
So where
kind of
would
pass
you-
the test.
where
So
would you say to put it?
immediately, the first thing. I know it's abdominal pain. I know this is going to take some time to work it up. Patient placed an observation for
I got
abdominal
Chris,
pain.
are you asking about like if after the fact?
Yeah, so at the end of the case, we're ready to discharge.
Just go back and put it right
So add
above
it
where
to
you
like
started.
HPI, for example.
No, in your ED course. So if you did all of these things without saying that you put the patient in observation, you would, when you get to the end and you realize, oh, I've had the patient for 5.5 hours, I would just go back and put it right here.
We can't do that, Ron.
You can't?
It's timestamped. Every entry goes in chronologically.
So if we enter it, it's gonna be timestamped at the bottom, you know.
That's fine.
In the ED course, but we can just
That's fine.
say, it'll be
Yes.
timestamped at the time, but we can say when they presented.
You can do that while we're on this learning curve of, recognizing we should put it up ahead. And the thing that we're going to keep a list of these so RTI is going to know that's one of the patients. So if you do that, you're going to put it on the list. This is an observation patient. They're going to look through, they're going to find all your documentation. Just may not be in the usual order, but it'll all be there.
We can change the times if we want to. I did not know that.
Okay, next slide. Okay, so the providers are documenting the services they're providing. We're making some recontact with the patient to make sure our reassessments are clinical. All addendums are on the original record. Just the way you said it would be fine. If you put that down at the end, patient was observed for 5 times, for patient placed in observation, 2100, total observation time 7 hours, that would be fine. All right, medical records should accurately reflect all the services and the items furnished. If it was not ordered by the physician, then it should not be billed. And in no case should you indicate that a service or item is medically necessary unless it is supported by the patient's medical record. Okay, so, yes.
So if you take a provider that's just very aggressive, you could, assuming our average per stay is greater than 120 minutes, it's like 180 minutes, 190 minutes. You could technically on every chart, almost the majority of your charts say the patient when placed in op status. So I guess the question is, one, have you seen abuse of it? Two, like for your patients that haven't had a major stay of greater than 120 minutes, how many patients are getting ops codes? And then what is like a general, like we used to get a percentage of our patients that we would document critical care, which is, I don't know, it's like 6 to 10 to 15% among our providers. What's the average for like a site that you've seen?
Well, it depends on what you mean by aggressive. So aggressive would denote that this was a patient, maybe you didn't really have any disposition or diagnostic uncertainty about. But many times when you start a workup, you actually do, because you don't know what that workup is going to provide you. And as you said, your critical care, 6 to 10%. When you look at this, you realize there's a very large cadre of patients who could go into observation. So 15 to 20%. We've had sites as high as 40, and we've actually audited some of their charts, and many of them were appropriate. So it really comes down to what's your acuity, what type of cases are you seeing. But we wouldn't want to see you put 50% of your patients in observation.
Will RTI not code for it if it doesn't, even if the documentation's there, but it doesn't meet the appropriate criteria? They're just going to do it.
They really don't know if you put it in there, because they're not clinically oriented, so they really can't question if you say that the patient has some diagnostic or disposition uncertainty, and you put it in all the documentation, they're not going to question it. So it's really for our internal review. So we do review the sites, and if we see someone who has inordinate numbers, we do look at that, because we don't want it to trigger an audit for the rest of the division. Okay, yes?
Rob, are there any unintended consequences as far as RVU capture for other procedures or other things we do? Is there any caveat of, aside from, like you said, about the timeliness of it, is there anything that we need to know about a patient that has say procedural sedation during their stay, I'm thinking of the patient that's recovering, you put their hip in and they took them an extra hour or two to kind of wake up from their anesthesia, from their
So in
sedation.
those particular instances, because of The intra-service time with, moderate or conscious sedation, those really wouldn't be observation patients because that recovery time is still part of that conscious sedation. So you'd have to have a different reason for that. The other thing that we try to caution the providers about, because we talk so vigorously about observation, then you find they have an elderly patient who comes in, the blood pressure is 80/50, and they've been vomiting, having diarrhea, they start hydrating them, and then have all these different reassessments. It would have been much easier just to meet critical care off the bat because the documentation requirements are much less. The patient was hypertensive. It's obvious that they're critical care. Those reassessments are required for critical care as well, but you would have met the burden of your treatment time much earlier because you would have been past 30 minutes.
What is that critical care RVUs compared to observation?
They're pretty similar, actually. So critical care is probably 6.9. A 236, the single day code is probably right around the same thing. It's the 2-day code that's actually a little bit higher. But usually when you're doing critical care, those don't get down coded. Because of the severity of illness, they're not looking to down code those for some reason.
So there's no financial advantage to have a patient that you're giving critical care to also sign an observation to?
Well,
Or is that incorrect? Like if you had
there's-
someone that
you're-
provided critical care, but then an issue came up, let's say a psych patient that was initially combative and hypertensive or whatever, and you had to do all this stuff for them, but then you had to monitor them and watch them for a period of time, and ultimately they were able to be discharged or whatever. Is that, and you did reassessments after they had stabilized and were no longer critical care, but you had already provided that initial critical care? Okay,
so when we had our conference call with RTI, we kind of addressed that. In general, these are considered evaluation and management codes. So whether it's a straight level 4, level 5 E&M code, if it's observation, critical care, they're all some form of evaluation and management code. So usually the payers are only going to pay you one of those per day. Now that example you gave of the psych patient where initially they're combative, blood pressure is low, we're doing critical care, that would be our evaluation and management code. If you're caring for that patient across midnight, you could code for an observation, but it's going to require you to do a completely separate note. So it's going to have some arduous documentation that you have to do.
Separate note like on the,
You have to give another history, re-examination. You're going to have to give all the requirements for that because they're going to put all the history, examination, decision-making into the critical care. Now you're going to have to recreate that to code for the second code.
So if, for instance, Mike's one of our night docs, if I sign out to him at 6 o'clock, the patient's waiting for our psych eval, I documented critical care based on kind of my time with them. They cross midnight. He could then, if he did another HPI, documented it, could then put in for observation status, and those are additive RVUs?
Yes. Those are additive. The only question would be, it's totally appropriate for you to do that. Doesn't mean the payer's going to pay us.
Gotcha.
But we would be in the right, but doesn't mean they're going to pay us. You got a question over there?
Sorry.
You had a question?
I think we have a lot of those already in the pediatric patients when the area closes here at Shade. When it closes and then we sign over, we don't sign over to the doc that's working with us. We sign over to one of the night docs because we know that that workup's not
Right.
going to be completed at that time. And then my other question was, so we get a lot of these patients, these ground level falls, where they hit their head and we need to do the laceration repair, but we also have to watch and make sure that they're able to go home after the workup's done. So will we be able to count for both the observation and the procedure?
Yes.
On
The
the same?
procedure is separate.
Okay.
Yeah. So your evaluation of that head trauma patient is really the observation, and the procedure is separate.
So the 5 minutes to do the staple won't matter in the observation code?
In the overall time, no.
Okay.
Usually you have to subtract that time from critical care, but usually your service is not, that tight. It's not like, so even for observation, it's not going to matter.
Rob, can you clarify again what you said about Medicare and non-Medicare earlier?
So Medicare has a 8-hour rule for you to use the 1-day codes, the 235 and the 236, but that's really for the billing company to worry about. We're just providing the documentation, and then they kind of calculate the times and which codes to use. So if you had a Medicare patient comes in at 12 noon, you get labs, you get CT, you discharge them at 5 p.m., you put in your observation documentation, they're actually going to code that as a 99220, which is the fraction of the code. That's pretty similar to a level 5. However, it's better documentation. It reduces your distribution of level 5s and kind of takes you off the audit radar
Well, that's
for
what I was
other
thinking, if
reasons.
if you only get, say they were there for 4 hours, and you thought, oh, I'm trying to capture my RVUs, so they're only there for 4 hours, you put them in an offset, it's a Medicare patient, now you're getting 50% of that RVU, I'm sorry, 50% of that OBS ENM code, when really they would been level 5. I wonder if actually you're doing yourself a disservice.
They're both about the same. That 220 is probably about the
So
same amount of
50%
RVUs as
of
level
the
5.
Whatever.
Because it's not 50%, it's actually higher than that.
If they're only there for, if 8 hours is the full
The full
status,
code.
and they're only there for 4, even though they're only there for 4, it's not, I guess I'd hate to give people direction and then only find out that we're actually creating a lot of extra complication.
The actual RVUs for that 219 and the 220 are very similar to 4s and 5s. It's the 217 that pushes them up above that.
That's what I mean, is if you're only billing a percentage of that full code, I would think that in the end of the day, you've actually reduced your RVUs.
No, what I'm saying is the percentage of that code is actually equivalent of a 5. So if that was going to be a level 5, they're the same. There's no, you're not losing anything. You're just getting all the additional benefits of the documentation, being more bulletproof, reducing your level 5s, so that now you're not at 50% level 5s, maybe you're 40%, 10% ops.
We like our level 5s.
What about to the patient? How does that affect kind of what they're responsible for? Because we've got a pretty savvy patient population, and if you mention observation status to them at all, they freak out. And so how does that change what their responsibility?
It is an outpatient code, so for the Medicare patients, they are kind of aware of where it comes on their Medicare Part B, where they still have a percentage that they're responsible for. However, you were kind of going to do most of that, so it may be a little bit of an additional charge for them.
So
It's not going to be the equivalent of putting them in observation in the hospital, though, where they have that hospital bed.
Expenses going to go up for that ED visit.
Yeah, it's going to go up a little bit above a level 5 because you can already see that those additional RVUs, they're going to have a percentage of that they're responsible for.
Because they will beat you with a cane here.
Rob, what about the effect in that scenario with the Medicare patient as far as other ancillary tests? Because correct me if I'm wrong, if they're in OB status in the hospital, let's say they have an ultrasound, they have this, that, all those things fall in a different status than if they were inpatient. So similarly, are we committing then the patient to a higher facility fee or charges for this a la carte stuff? Instead it was wrapped into their bill and they got it in a level 5 code. Now they're going to get the hospital saying, well, you had an ultrasound, you had a, et cetera, et cetera.
The difference, well, when they had that level 5 code and the CAT scan, the price would still be the same because they're outpatient. So observation, they are going to have to pay for those a la carte services, but you'll find your facilities don't want you to reduce your number of admissions. These were probably patients who would not support an admission to begin with. So even though the patients may be aware of this and not want to go into observation, they weren't going to be admitted anyway. You know, so you wouldn't take away an admission and make it an observation so you can charge all these additional fees. That's really not what we're advocating. So if it was an admission like for diverticulitis, that's still going to be a slam dunk admission. All of those codes are going to go under the DRG and they're going to be covered. But if it's one of those focal diverticulitis and they get OBS and they get discharged home, there's really no way to avoid that.
So like, for example, you know, if you have a level 5 going, there's a CT appendicitis, it's a level 5 going, oftentimes there's no complication from that standpoint. But if it's under, if you bill it as an OBS and they get a CT appendicitis done, then
I'm not aware of there being a difference because they're both outpatient codes. So whatever, and it's the emergency department evaluation, so whatever, if it's covered under that 5 with the CT, it should be covered under the odds with the CT. You know, I don't know all the different arrangements for their payers, but that shouldn't be any different.
Sorry to make this trite then. So what I'm hearing, just so I have it summed up in my head, is that the level 5 bill and the OBS bill, RVUIs are about equivalent.
Only for the Medicare patients.
Only for Medicare.
Yeah,
How about
because
for
they
the
have it.
for the
They're
non-Medicare?
not equivalent.
Not equivalent.
It's higher RVUs.
For OBS.
Yes. It's only equivalent for Medicare because of the 8-hour rule. If it's a Medicare patient who's there for 8 hours to get hydration, CAT scan, evaluation by surgery, gets discharged after 8 hours, it's going to be the same as it is for the non-Medicare payers. So it's only the 8-hour rule that makes the difference.
So like a person that comes in, you know, they miss their dialysis, we have plenty of those, we get them dialyzed, they come back down, reassess, so those are appropriate for that status.
Yes.
And then lastly, is there any financial implication for the hospital, positive or negative, when we change the status in the ED?
Positive for the hospital.
Positive, so that they will like that from us.
Yes.
So positive is what though?
It's the
That they're not
facility
gonna
side
be-
of observation. Because there's a facility charge for that as well.
So we need to communicate with the hospital that
Yeah.
these discharged patients, we are going to be starting to bill as OBS, theoretically. That they should start billing, you know, a facility fee.
The way it worked for our system, so when we were EMA, we had our own electronic medical record system, orders, full suite, and at the start of each order set, it said place an observation. That was like automatically checked for abdominal pain, chest pain, if you were a hydrated patient. So they got all of those observations. And then in their infinite wisdom, they went to a new system, and we kind of told them you're going to lose a lot of money, in which case the new system didn't have the same order sets, and the providers were responsible for putting it in. Needless to say, that dropped off tremendously. And they lost millions of dollars for those observations. And so they've kind of been on our back constantly to put in that order for all of those observation patients.
Rob, any other effect on bills for medications in the emergency department? Would the Medicare patients see anything different for the medications they get if they're just
I don't think
level
so.
5 versus they put into OBS? Is that?
For those, I don't think so. I think their issue with usually is, well, for us, it's probably usually our observation unit, because they think they're going in the hospital when you send them up to the observation unit, and then they come to realize they're outpatient, they're getting their stress tests, and consult by the cardiologist and all these things, and then they do get a big whopping bill for that. And so that's usually where they have a problem. But the other side is you couldn't admit that patient anyway. You know, if you tried to admit them, that admission would be denied, and a lot of the facilities have come up with a mechanism to stop you from the case manager or somebody to review that to say, no, this doesn't meet admission status. So,
You mean the inpatient status, is what you're saying?
yeah.
How does it affect it if they get, instead of admission, they get transferred to an outpatient facility? You're waiting for a psychiatric bed to become available, so that's essentially a discharge code, so you can count that as an OBS while you're waiting for them to go to a psychiatric facility, because you're...
It depends on if you made the decision, because when you make the decision, so patients being transferred, you know, psychiatrist wants to transfer, that's kind of your disposition decision. In our particular facility, so I go see the patient, and I'm doing the medical clearance, I order their labs, I order the psych consult, I make them observation. So now I'm reassessing them for whether or not they're medically clear, I'm waiting for psych to evaluate, it usually takes a long period of time. Then my stop time is when they decide, well, actually it's not. They may be looking for a bed, that doesn't mean a bed is going to be still under my care. So it's not until they actually leave, you're correct.
So what if they end up getting admitted?
If they get admitted, that's the stop time. But still, what you're getting credit for is the medical clearance, the observation that you're doing during that period of time, having to medicate them for whatever. The patient's agitated, you have to give them some Haldol. They're anxious, you have to give them Ativan. You're checking to make sure the x-ray is
Is there
clear.
a time frame for them that they have to meet for that, to meet that observation code?
We use a 2-hour threshold.
But what happens, so if they admit them, they can't admit them under observation status anymore?
In my place, they usually don't. They make a flat-out admission.
Yeah, well, obviously, this is the kind of the first foray into this discussion. This isn't something that we've got all the kinks worked out, obviously. This is, the concept here was just so we kind of understood the documentation piece of it. There's a logistic piece that we're going to need to work on as well, so far from the last. I'm getting a hard rap from the people saying they're going to go in for lunch, so unless anyone has any really high-level questions, we'll end and say thank you, Dr. Giles.
Oh, you're welcome.
Appreciate it.
And if we